Is this a case of beta hCG negative choriocarcinoma or a placental side trophoblastic tumor? So she was a 24-year-old para 0 plus 2 whose last menstrual period was 2 months prior to presentation. She presented with a 2-week history of recurrent vaginal bleeding and lower abdominal pain. The bleeding was associated with passage of clots and fleshy material. She had features of anemia. This patient underwent 3 manual vacuum aspiration. However, the histology report is not available. She attended Koitaki at the age of 18. On examination, she appeared chronically ill-looking and pale. There was no palpable mass per abdomen. Vaginal examination revealed an irregular cervical mass that bled on contact. The synologist wanted to take a biopsy, but because the bleeding was profuse, he decided to pack the vagina and prepare her for biopsy and anesthesia. Patient subsequently developed cough. A chest X-ray was requested together with the urine pregnancy tests. But patients and her family left against medical advice, attributing her illness to spiritual causes. Unfortunately, I was informed that the patient died at home. So we couldn't do the chest X-ray. All we got was the urine PT, which was negative. If she was still with us with a negative urine PT, we could have requested a human placental lactogen, but that was not to be. Some reasons for a negative beta hCG in choriocarcinoma. Remember that what produces the beta hCG is the syncytial trophoblast. So if the tumor is largely cytotrophoblast, then there will be little or no beta hCG produced. The tumor undergo anaplastic change or tumor de-differentiation because the tumor is highly vascular. It can eat up itself and undergo necrosis. It's possible that the assay is sensitive to some hCG variant, and in cases of non-gestational choriocarcinoma. Of course, laboratory issues like the hook effect, which gives a false negative pregnancy test because of the extremely high beta hCG that overwhelms the assay. But this has been ruled out here because the serial dilution was also negative. Now, there are two important differential diagnoses here. It's either a beta hCG negative choriocarcinoma or a placenta side trophoblastic tumor, because CA service is out of the way. Now, in relationship to pregnancy, yes, both are related to pregnancy. But the serum beta hCG could be normal or just mildly elevated in placenta side trophoblastic tumor, but is usually extremely high in choriocarcinoma. The urine PT almost always positive in choriocarcinoma, but it's negative in placenta side trophoblastic tumor. Bleeding pattern, persistent heavy bleeding in placenta side, heavy bleeding in choriocarcinoma. Cervical mass, commonly seen in patients with placenta side rather than with choriocarcinoma. Bleeding can be profuse in both, but weight loss and cachexia is seen in both, but weight loss is seen earlier in placenta side than in choriocarcinoma. Ultrasound findings, it was usually empty in placenta side, but one could see an empty uterine mass in choriocarcinoma. Doppler findings, there is marked vascularity and turbulent flow. We have marked vascularity in choriocarcinoma. The arcuate vessels are often prominent in placenta side, not so in choriocarcinoma. Common site of involvement in placenta side, lower uterus, cervix, prostata, and vagina. Commonly choriocarcinoma is the uterus. Metastasis usually late in placenta, long metastasis usually late in placenta side, common and early in choriocarcinoma. So let's look at the video of this case. You can see the transabdominal image. Bladder is underfilled. This is the uterus. This is cervical mass. So you can see the cervical mass here. You can see the lower uterus here. Part of the corpus, I beg your pardon, thecal luteal cyst somewhere here. Look at the uterine cavity here. It's empty. It's apparently normal. Look at the uterine cavity empty. Look at thecal luteal cyst. And not the prominent aqueous vessels here. And not the turbulent flow here. Not the turbulent flow here. Look at the prominent aqueous vessels. Empty uterine cavity. Look at the neovasculature in the lower corpus and the cervical mass. Note the dirty shadows here is consistent with the malignant lesion in the cervix. So look at the lower corpus. So here again, trying to demonstrate whether there is an infiltration into the bladder mucosa. You see that? Apparently, there's infiltration of the bladder mucosa. So I asked the registrar, any history of hematuria? He said yes. Patient complaint of intermittent hematuria. So you see that? There is infiltration into the bladder mucosa. So don't confuse these foreshadows because this is coming from the prop here. You can see because of faults, maybe a fallen prop or something. You can see these shadows. So don't confuse these shadows and misinterpret the case as something other than a malignant condition. So you can see all these features here. But what is interesting again is thecal luteal cyst is commonly associated with high beta hCG. Here you have undetected beta hCG both in the serum and the urine, but you also have this thecal luteal cyst. But again, not the prominent aqueous vessels, turbulent flow. This is a thecal luteal cyst. So these are the still images. This is part of the thecal luteal cyst. This is the empty uterine cavity here. Look at the prominent aqueous vessels. And look at the neovascularization here. This is on color Doppler and on 3D. So again, this case here. So I decided to bring up this case of a 40-year-old Paraten with histologic diagnosis of choriocarcinoma so that we can compare these two images. Here you can see the still image of this case, this is the still image of this case. We have seen this video, just not some few areas which I want to compare with this, not the empty endometrial cavity here, not the prominent aqueous vessels here, not the involvement of the cervix here, with these dirty shadows here. So and presence of the thecal cyst, and look at the turbulent flow here. The turbulent flow, you see that? Turbulent flow here, prominent aqueous vessels. So let's compare with this historically confirmed case of choriocarcinoma. You see, this is the endometrial cavity replaced by this heterogeneous tumor. See that? Here, note that the aqueous vessels are not prominent. There is no cervical involvement. not the lesion here in the endometrial cavity. You can see part of the normal mammary here. This lesion, not that the affected arteries are not prominent. Part of the cavity cysts here. So this was a case of choriocarcinoma. So what is this? Based on these findings, my working diagnosis here is more likely to be a case of placental side trophoblastic tumor rather than the case of beta hCG negative choriocarcinoma. So I take a message is that it's extremely important not to misclassify placental site as choriocarcinoma. Why? Because the treatment of placental site is surgery, while the treatment of choriocarcinoma is chemotherapy. So if we misclassify a case of placental site as choriocarcinoma, one can just imagine the dire consequences of that misclassification. So thank you very much for listening.